moderators, and members of the floor. Today, I, Goanting, will be your chairperson for the debate entitled RCT versus Implant. On the right, we have the RCT team, which consists of Shiri, Junita, and Cheryl. On the left, we have Implant team, on Shihab, Loziu, and Azim. It is an honor to present Shiri from the RCT team as the first speaker, and please welcome her.
Thank you to the chairperson, and a very good morning to Doctor and friends. I am the first speaker of the RCT team, and first we would like to start with a brief history of RCT, which began in the 17th century. Since then, there have been numerous advances and developments and research that has proceeded continuously. Owing to the efforts of these researchers, patients today can be assured of predictably reliable and safe endodontic treatments, the success rate of which, as perhaps in no other branch of medicine, approaches 100%. The aim of the endodontics has been defined in terms of prevention and/or elimination of apical periodontitis by providing fluid-tight seal at the apical and coronal region. So, some of the indications of RCT is irreversible pulpitis, pulp necrosis, traumatic dental injury, and elective RCT for added retention of a crown. Moving on to my next point is the advantages of RCT. It eliminates the dental pain and is much less invasive compared to dental implant. It also prevents spread of infection as the teeth are sealed to reduce the chances of infection and eliminate the need for removal. The procedure protects other adjacent teeth from infection and strain. We believe in the idea of preserving natural teeth, and root canal is the best treatment compared to implant because you don't have to live with an artificial tooth. RCT helps retain the natural tooth for function and aesthetic, allowing the tooth to continue to serve the patient as is expected for natural eating and speaking. Another benefit is that tooth extraction is not required after a root canal treatment and the bone around the tooth is not lost or damaged. There are many clinical reasons for needing root canal treatment, but there are also countless practical reasons why saving the natural tooth is a wise choice. Endodontic treatment helps maintain a natural smile. With proper oral care, most teeth that have had root canal treatment can last a lifetime. Root canal treated tooth may be restored using a crown, which can significantly improve the appearance of the tooth, and it can be color matched to the surrounding teeth to give a natural looking smile. Root canal also helps restore the health of the periradicular tissues. Moving on, I would like to highlight on the disadvantages of dental implants. With every artificial prosthesis, there ought to be some disadvantages along with its advantages. Dental implants are costlier than any other tooth replacement dental prosthesis in use, and the price is always a matter of thought for every patient. In Malaysia, an implant procedure costs at least 5,000 ringgit and above for just one tooth. However, for root canal treatment, it depends on which tooth we are doing root canal treatment, either the anterior, premolar or molar, or surgical endodontics, but it will not be as costly as an implant procedure. Furthermore, equipment required for implant is very costly by the dentist, which in turn increases the rate of the implant procedure. The use of CT scan and specialized radiographic procedures for diagnosis and treatment plan considerably increases the treatment cost of implant many folds compared to RCT. There is also anatomical limitations whereby dental implant placement requires the presence of proper alveolar bone height to support the implant prosthesis. In old age, the lack of bone support is a major hurdle. Lastly, the procedure time for dental implant is very prolonged. There are many steps in the procedure, and after the placement of implant prosthesis in the bone, we have to wait at least 15 to 30 days for proper osseointegration to occur, which is a must for the success of dental implant in the long run. And these steps make it a very prolonged procedure compared to root canal treatment. That's all for me. Thank you.
Next, I would like to welcome the first speaker from Implant team, Shi Hao, to present his point.
Thank you, Chairperson. Very good morning to members of the floor. And first of all, I'd like to congrats Shireen for your excellent points. I would agree with your points regarding the advantages of the RCT, because who would want to argue for a good thing, okay? However, I slightly disagree with you when you talk about the disadvantages of implant. So I would like to rebut some of your points. First of all, you talk about cost. So it is true that an implant is more costly than RCT. However, I would like to explain that this is worth the final result and quality of treatment that patient will receive in the end. And at the first place itself, it is not fair to compare the cost of RCT and implant simply just because of the difference in material, armamentarium, and equipments for each treatment. Bear in mind that in implant, you are replacing a missing teeth. You are inserting a biocompatible material into your body, which is a titanium, and it will last as long as there is bone there. Besides, the cost is also attributed to the more complex procedures and sophisticated equipments such as the surgical sets, drills, more advanced imaging modalities, and so on. All of this is for us to have a better quality of treatment in implant. Furthermore, do not forget that in RCT treated teeth, the tooth structure will be weakened. Post, core, and crown treatment will have to ensue to increase the longevity of RCT treated teeth. Therefore, this in turn can address the point where you say about the prolonged procedure time, complexity of treatment, multiple visits, and also cost, as endodontic treatment can be complex, require multiple visits, and costly as well. Okay, after I have rebutted your points, please allow me to talk about some positive points for implants. First of all, implant is a more suitable option when restoration extends beyond the gingival level. Teeth that require endodontic therapy have frequently experienced some type of catastrophic event. This could include extensive fracture or advanced tooth decay that extends subgingivally, and in such conditions, the tooth may be so deteriorated that rebuilding the tooth is impractical or ill-advised. When restoring a tooth, I think we all understand that it is a must for the restoration to be placed where it is not violating the biological width. If this rule is broken, periodontal health around the tooth will be a perpetual problem, and worse, it is likely affecting the neighboring teeth as well. Therefore, at the end of the day, not only will RCT fail, but the neighboring teeth will be compromised as well. However, a surgical procedure termed crown lengthening can be performed to remedy this situation. But bear in mind that by doing so, it also removes some of the bone that supports the tooth and also from the adjacent teeth. And beyond that disadvantage, there's also the issue of additional time, including the healing time and expense of performing this procedure. And the next point is when implant is more suitable when it is questionable to complete the root canal treatment successfully. Routine conventional root canal treatment can be expected to provide a predictable and lasting outcome if only the work has been performed to a high standard of care. However, Mama always said that life is like a box of chocolates and you won't know what you'll get. Circumstances may exist that will increase the difficulty of RCT and ultimately result in treatment failure. This can include significant cracks within the tooth or roots, extremely curved roots or complex root canal morphology that is difficult or even impossible to adequately treat. Okay, for example, now I would like to ask all the members of the floor to close your eyes and remember back when the times you do the Mona RCT. Your 26, 27, 46, 47. Okay, imagine you go back to that time. So hard to find your corrector working length, even like access cavity is so hard. Then after that you do the cleaning and shaping, your instrument broken inside. Okay, then finally you settle, you take MGP, doctor say, okay, you can obturate, but suddenly you found out your MB2. So, okay, my tears almost fall out now. But if this is worse, how about when those root canal system, if you remember the Bertucci classification, or the 1212 or the 1234 canal system. So, how sure are you can clean and obturate these canals properly? And with regards to this, I would also use this opportunity to bring out a disadvantage of RCT, which is mistreated canals. It's not that you mistreat the canals, but you miss the canals. It is not an uncommon practice to miss a canal while carrying out endodontic treatment, especially in molar teeth, where one root, one canal formula is frequently overruled by the fact that the number of canals are more than the number of roots. The inability to treat all canals is one of the causes leading to endodontic failure. Bacteria residing in these canals leads to persistence of symptoms. The results of one study carried out on 5,616 molars, which were retreated, show that failure to locate the MB2 canal had resulted in a significant decrease in the long-term prognosis of those teeth. In another prospective study carried out by Hohen and Pink, the incidence of missed canals were reported to be 42% of the 1,100 endodontically failing teeth. So in such cases, implant placement can be expected to be a much better choice. Okay, before I end my presentation, I would like to talk about some risks of failure of RCT. First of all is, there is a risk for persistence of bacteria in RCT. The role of bacteria in periradicular infection has been well established in literature and endodontic treatment and will be affected with a higher chance of failure if these microorganisms persist in canals at the time of root canal obturation. As we all know, root canal system may not be as simple as it looks in the 2D radiographic image. I would like to use an idiom like air yang tenang jangan disangka tiada buaya. So each root canal system has areas such as isthmuses, dentinal tubules, and ramifications that may evade disinfectants and obturation material. Here I would like to plug in a microorganism which is frequently found in the infected root canal system, which is he is Enterococci species E. faecalis. This type of bacteria will display resistance to almost every antimicrobial agent. It can survive in environment even antimicrobial agent is used, and the only way of removing it is through mechanical debridement. But we cannot achieve the mechanical debridement in every space of the root canal system, such as the place that I mentioned before, the isthmus, dentinal tubules, and ramifications. So a study performed by Lin et al. On 236 cases of endodontic treatment failures found a correlation between the presence of bacterial infection in the canals and periradicular rarefaction in endodontic failures. Treatment is more likely to fail in these teeth with pre-treatment periradicular rarefactions than those without these changes. And also, RCT also bears a risk of improper. Let's see. Okay. Okay. Let me end my last point. Okay. So RCT treated teeth bears a risk for improper coronal seal. A well-sealing coronal restoration is essential after the completion of obturation, as it will prevent any ingress of any microorganisms which are present in our ambient oral environment. Swanson and Madison emphasized in their study that coronal leakage should be considered as a potential factor resulting in endodontic failure. If there is reinfection of the tooth, not only will patient and the operator have to go through all the procedures again and also doubling the cost, the success rate of endodontic treatment will also be largely reduced. Okay, that's all from me. Thank you.
For the points. Next, let's welcome Gita from the RCT team.
Very good morning to the members of the floor, and today I am Julita, the second speaker of today. I would like to give my points today on why RCT is the better option than implants. So I would like to direct one question to the implant team. What is the ultimate goal of dentistry? It is to retain our natural tooth, not to replace it. So, although there is a tendency which exists to extract and place an implant, which is much more easier, but in real life the truth is it is not that simple. So my first point of the day is patient preference. According to a study done by Doyle in 2006, it has been proven that patients chose RCT again as the treatment of choice rather than having implant again in their mouth. So this is because RCT is known for its non-surgical approach and it is less complex and it has a higher success rate than implants. I'm talking about higher success rate because according to University of Minnesota, they compared endodontically treated teeth and implants, and they had a very obvious positive outcome of endodontically treated teeth compared to implants. So I would like to ask, why would you choose a more complex treatment that has a lower success rate, but you have root canal treatment which has a lower complexity but higher success rate? So going to my next point, RCT is comparatively a less complex procedure. Okay, according to a study done in 2011, the success rate of RCT done by endodontists has a success rate of 98%, and the success rate of RCT done by general dentists are equally impressive, which is 90%. But this does not repeat in the case of implants, where when it's placed by specialists, the success rate is 95.5% in implants, but when it is placed by inexperienced dentists, the success rate falls to a number of 73% only. So, isn't this obvious as told by Mr. Shihao? Alright, so implants are more difficult treatment comparatively because we have to restore the aesthetics and gingival architecture, and this is even a big challenge to specialists. So, this is even harder when patients have a high smile line and also increased distance between interproximal contact point and alveolar bone. Moving on to my next point, is the importance of retaining our natural tooth. According to Gayton, in 2011, majority of people with implant has given a feedback that they have a feel of the artificial tooth feels different than their natural tooth. This is because the periodontal ligament binds to the tooth in the socket, providing a sensory feedback. So, other than that, implants also integrate with your jaw, which causes orthodontic movement of the teeth not possible. And there is also a negative psychosocial impact when there is a tooth loss to patient. So patient prefers to have their natural tooth intact by choosing the less complex procedure, which is root canal treatment. So moving on to my next point, which is medical contraindications and increased risk for implant failures, such as patient undergoing chemotherapy, biphosphonate medications, severe psychosis, pregnancy, clenching and bruxism habit, especially recent myocardial infarction, uncontrolled BP, and diabetes mellitus, immunosuppression, bleeding disorders. Other than that are also poor oral hygiene and smoking. With so many contraindications and risk of failures of implant, RCT will be the obvious choice for us. And if implant is still placed, regardless of all this, there will be a tremendous loss of money, time, and failure of treatment. So as Mr. Shihao has mentioned of violating the biological width, he has mentioned a surgical procedure called crown lengthening. I would like to mention that this procedure, crown lengthening, is far much more less complex than the placement of implant. And also sinus lifting and bone augmentation associated with implants. So why not just do crown lengthening? And talking about complex root canal morphology, we are living in the era of modern endodontics, and we have many advances in endodontics today. And the rate of success of RCT has been proven to be higher in endodontics. So, we have also many advances such as electrometric length measurement devices, microscopes, which we can view complexity of root canal morphology, and advanced irrigation and disinfection protocols, and also CBCT to help us in complex cases of endodontics. So why not choose the less complex procedure, which is root canal treatment, rather than the very complex implant? Thus, I would like to come to a conclusion today, saying that root canal treatment is the better option than implant placement, and nothing is better than the original, and we have to retain our natural tooth, whatever it takes, by taking whatever it takes.
Thank you, Dinita. Next, please welcome Lo Ziyu as the second speaker from the implant team.
Okay, very good morning and a bit to respected doctor, honorable juries, and also members of the floor. Thank you very much, chairperson, and also the timekeeper as well. All right, first of all, here we are today, we're talking about RCT and we're talking about implant. Which one is better? Alright, I have a few things to rebut to my dear friend Janita here. Thank you so much for your points just now. As we heard what Janita said, that is that you must always retain your natural tooth. That is the ultimate points and aim of dentistry at the end of the day. But then, if you think about it, when it comes to a point where your tooth can no longer be restored, it is already really badly broken and there's nothing you can do. Who do you come to? Implant. It still comes back to implant over there. Okay, now we also hear from Janita talking about success rates, comparing the success rates between dental implants and also endodontic treatment. Yes, Janita has talked about the success rates of RCT being higher, but we also have studies that show that implants have a success rate that is higher. You must also come into perspective and think that what kind of factors determine tooth is success or failure. Because in the papers from Fletcher et al., it is a very different approach, and then the success rate for implant is still higher. I will go to that point in my presentation later. Next of all is also, Janita talked about the same thing. A general practitioner doing an implant will have a lower success rate, and then it is from an inexperienced dentist. Yes, similarly, we cannot use such an enclosed area to talk about the success, because if an inexperienced dentist does a complex RCT, there is still a chance of failure as well. Also, Janita talked about the artificial sensation of an implant in comparison to an RCT. Yes, it is an artificial sensation, you would say, but at the end of the day, if you have a working, functioning tooth that is there, it is still better than not having any sensation there at all. Okay, also contraindications for RCT and implants. I would like to drag you all down with me as well, because you talked about contraindications for these implants. I would say, yes, I agree, but all these contraindications are for you as well. So let me ask you a question. If it is contraindicated for implant, does it not contraindicate for endodontic as well? For example, just now you mentioned about uncontrolled hypertension, in a sense. So the reason is contraindicated is regarding issues of drug interaction of LA with non-selective beta blocker. It may increase LA toxicity. Besides, the cardiovascular effects of epinephrine may be potentiated by the use of medications such as non-selective beta blockers like propranolol or nadolol. But I'm sure that in doing endodontics, we also give local anesthesia, isn't it? So as long as we choose the correct anesthetic agent, give safe dosage and carry out appropriate prevention, this will not be an issue anymore, right? So the same goes to uncontrolled DM. The problem in uncontrolled DM patients is that they have much reduced healing capacity in endodontics. Often the infections has spread to perireticular region. Cleaning the root canal system itself is not enough to ensure success if the hosts do not have the adequate healing capacity for the bone and the periodontal tissue. Besides, as we know, uncontrolled diabetic patients is strongly associated with poor periodontal health. Therefore, even if we carry out the best endodontic patient, but if patients do not address their systemic problems, endodontic treatment will still go to a waste. It's the same for both of us. So, alright, now I come to my point. So, as we know, using dental implants, this kind of treatment has been gaining more popularity for the past 2 decades. As we come to this point, patients are always given the dilemma. If the tooth is already so broken down and there is a problem with it, isn't it just better to just extract it and replace it with an implant, a strong and sturdy implant? Now, comparing the success rates of the two procedures critically, so when considering this choice, it is important to assess the success rates very critically in the debate. Every increase or decrease is still an increase. Okay, so according to Fletcher et al. From 2008, title study about endo-osseous implants versus non-surgical RCT, it shows that the success rate of RCT range from 92 to 97% over a 4 to 8 year period. The success of dental implants is about 95 to 99% over 2 to 16 years of study. Now this study takes over many years of different papers to come into this conclusion. Yes, I agree. Both these treatments have very, very high success rates. Yeah, both of them are very high. However, there is still a slight preference to implants, being 95 to 99%. Okay, and also over a longer period of study from 2 years to 16 years. So this is the slight preference I'm talking about. So by being very critical, implants is still better in this study. Now, as we addressed already about the success and failure rates, we talked about failure of RCT and its decrease of its success in the retreatment. So we established already there's a slight preference to implants in our stand. And once again, patients will be put into the dilemma when they have to do a retreatment. Should I just extract it and then just put an implant instead? It already failed once. Okay? So although root canal treatment, initial success is very high, like I said just now, there is a less confirmed level of success when it comes to retreatment. And then when the case progresses to the part where extent of apical surgery is required, the predictability of the outcome of this treatment will fall even lower. Okay, so to support this case that I'm bringing up here, Di Matteo et al. From 2008 also stated that retreatment can be done conventionally, no problem. But once surgical intervention is required, assessing, yes.
So you're saying that about retreatment of surgical endodontics, using surgical endodontics. So isn't that a far less complex procedure compared to implant placement?
Yes, I agree. From your perspective, it's already going to the extent of as complex as implants, right? So in a sense, if it's already until that extent, right, why don't we just go for implant instead? Because when surgical intervention is required, like assessing tooth root with gum incision and bone removal, so it's more or less similar in terms of technical difficulty as implants as well already. So why don't we just go for implants, because it is the better choice according to me, the study in Di Matteo et al. So these are my points. Thank you very much.
Thank you, Sue. Now, please welcome Cheryl as the third speaker from RCT team.
Okay, a very good morning. I bid to Chairperson, yes, Dr. Shah, timekeeper, juries, and members of the floor. So yes, very good points just now. See you. And so now I would like to ask you back, how many teeth are actually badly broken if you want to consider to do RCT or implant? So now we have 42 of us. So are 42 of us all doing RCT in badly broken tooth? So yeah, exactly. So now, and you said that there is a very high success rate in implants. Okay, I agree in your study, right? But actually, the success rate can differ according to different studies. So you might say that this study is saying a high success rate, but the other might show another way, because what they actually determine is the survival rate. So that's what I'll be discussing that in my points. So from the study done in a meta-analysis by Doyle et al., there's actually 97% of success rate in RCT and also 94% success rate in RCT in implant. So this study said that there are more implants require some type of post-treatment intervention. Means you need to follow up more with the patient, and they will classify as surviving instead of successful. And then the clinical complications were observed in 18% of the restored implant cases and only 4% in RCT tooth. And this systemic review and qualitative analysis shows that implant studies spanning 20 years found that majority of the studies use survival over success. And then for the survival rates of success rate of RCT, we actually the outcome was to imply that the clinical measures, which means that patient is asymptomatic and there's no signs and symptoms, and also we have to see the radiographic measures, which is without periapical radiolucency or decrease in PA lesion size. So in teeth, for failure rates of implants, one of the reasons of failure rates of implants is peri-implantitis. So this is actually diagnosed by bleeding upon probing after you place the implants, and if there is pus formation, and also in combination with the radiographic bone loss. This is by Heinz Mayfield, 2008. And besides, there are also biological complications which can compromise any type of peri-implant diseases, and a large varieties of technical complications will occur when you place the implant related to mechanical damage of the implant, implant components, and also the superstructure of the implant, which includes suddenly, let's say your patient chews something hard, so it might cause implant failure, abutment oral occlusal screw components, and also the fracture of the veneering and also the framework, as implant has a more structures compared to RCT. And for the causes, I would like to continue with mechanical overloading on the metal fatigue. And where this metal resistance limit is exceeded, it results in fracture. And also overload can cause consequence of the patient's physiological alterations. For example, if patient has bruxism, parafunctional habits, so this might lead to more failures of implants. So in fact, the both centric and eccentric bruxism can lead to implant overload and also metal fatigue. And also, let's say your prosthetic origin, including inadequate occlusion, the presence of distal extensions or cantilevers in implant-supported prosthesis, and a lack of prosthesis passive fit over the implants can also cause implant failure as well. Yes?
Thank you for accepting. You say that implants will have from mechanical loading they will fail, right? So in that case, in RCT treated tooth, and just now from the first speaker, you also say that you can also place a crown. So in RCT treated tooth, and then it's indicated, and then there's breaking down, you do post and core and crown as well. Is it also mechanically stronger than implant, which uses titanium as its material?
Okay, that's a very good point. So actually what I want to stress is there are more structures, more complicated structures in implants, right? So that's why there are more specialist re-implants. So compared to the post and core and crown as well, of course the same, you can say the same occlusal loading, the same factors can also complicate both. But then we can see the structure of the implant as it is more complex, right? And as compared to the crown, post and core, which is a simpler procedure compared to the implant. Yes, so thank you.
Thank you, Cheryl. Finally, let's welcome Azim as the third speaker from the implant team to present his points.
So good morning. I bid to the chairperson, Dr. Shah, timekeeper, jury, and members of the floor. So today, I'm still standing here to protect my implant team. Okay. So between endodontic and implant, yes, again, proving which of these treatment option can create a better outcome is definitely difficult. One of the most debated components of the implant or endodontic dilemma is whether endodontic treatment can compete with a dental implant, and in terms of survival rate and success. So we move on to the survival rate and success of the RCT and implant. So regarding the success of survival rate, I admit that majority of study published or prove that the success rate between the endodontic and implant are more or less likely and sometimes no difference at all. For example, as mentioned by my team member, Zio, the second speaker, study done by the Malaysia in 2008, the success for root canal treatment and dental implant only ranged slightly difference, like 3% difference. And another study by Tara Bijahat in 2007 shows that 97% of the long-term survival for both of our treatment is slightly just the same. I'm rejected for a while. And as mentioned by the third speaker just now, she arrogantly said that the success rate for the RCT is very superior compared to implant, right? But how about the failure of RCT? Did she mention that? Okay, but still failure of RCT can happen in the root canal treatment. It still can happen, failure. And what I want to highlight is my point today is the complexity of the treatment after when the previous RCT was failed. And as mentioned by second speaker, she mentioned that our treatment is very complex compared to RCT, but they realized that when the RCT failed, our treatment will be more complex just because of their failure. we must consider how any treatment we perform will affect our future treatment plan. For example, in the case of failure of RCT, a common issue with endodontally treated tooth is that when failure does occur, the residual pathology can create a potential problem for subsequent implant placement. The bone resorption and damage from the infections of an endodontic origin, it can be extensive and require significant bone grafting and soft tissue reconstruction. This is according to the study by McGill in 2008. And also, retaining a compromised or failed treated teeth may lead to further continued bone loss, which could complicate again for the future implant placement. And this study was supported by the parent in 1991, 2000, 2002, and even 2003. And the residual bacteria remaining in the bone may colonize the implant surface, and the implant will then fail to integrate just because of your failure. And not just because of their failure. My next point is in terms of the bacteria itself. Other than that, the bacteria found especially Enterococcus faecalis, just mentioned by my team, or E. faecalis, the predominant species in fertility treatment, you know what they can do, this species can do. It can combine to the dentin and penetrate the dentinal tubule for a safe haven there. And then second is it can alter the patient's immune response or suppress the lymphocyte. And also third, it can form a biofilm that can protect from the antibiotics treatment or even resistance towards the antibiotic. So the antibiotic therapy during the osseous healing may not completely eliminate this vegetative form. After many weeks of osseous healing, if this site is drilled for an osteotomy and endoosseous implant, for example, we plan to reimplant, so we have to do osteotomy and osseous implant is placed, this vegetative form may then be reactivated back and colonize our implant surface. And later it will cause failure to our implant. See, the treatment can be so complex just because of the failure from the RCT. And moving on to my next point regarding the restoration used in the endodontically treated teeth. Okay, I believe endodontic therapy does not guarantee successful retention of the tooth. It depends on the type of restoration and the quality of the coronal seal, right? So for the long-term retention, for example, placement of post and core often are necessary to rebuild back the enough tooth structure to retain the restoration. However, need to remind, the added of the post for retention may be an increased risk for damage of the tooth structure. And this is supported by the Caputo in 1976. And also a study done by the Ruskin in 2005, the long-term ability of the implant to retain a crown is superior compared to the endodontically treated with supporting post and core, except the fact. And moving on to my last point, how about the financial status and the cost of both of the treatment? Yes, the financial factors may influence the decision making for both clinician and patients. Yes, I admit that according to the report by the American Dental Association in 2005, survey of dental fees, implant supported crown costs about twice than of the endodontically treated teeth with restored of the crown. Yes, you are more expensive. But in case of failure RCT again, according to the Kim and Solomon in 2011, a single implant supported restoration was more cost-effective treatment option despite of its high survival rate compared to do the treatment of the RCT, which is involving more cost to do either non-surgical treatment or endodontic microsurgery. So our cost will be much or less the same. And so, yeah, why don't you choose implant over to the RCT? If the RCT fail, you have to go all over the process again and to do the treatment, and the cost will be slightly just the same as the implant. Okay. And that's all. Thank you.
Thank you, Azri. Now let us welcome Cheryl to sum up the point from the RCT team.
Okay, so as summary, okay, thank you implant team. As summary, we would still stand firm that RCT is much more superior than implant. Okay, as it has its many advantages. For example, it retains natural tooth, it is less costly, right? And also with the technology advancement nowadays, of course, anything can be overcome as time passes, right? And it also is proven that more patients actually prefer to repeat endo than to go for implant. And even GDP, general dental practitioners have higher success rate RCT, like what we're doing now, compared to implants, which we don't practice here yet. And of course, nothing can replace the sensation of our periodontal ligament, original one, and the presence of the root surface in our bone jaw. And so the ultimate goal in dentistry, I would like to stress, is to retain our natural teeth in a good condition as long as possible, okay, for good aesthetics and also function. So save your teeth while you still can. Thank you very much.
Finally, let's welcome Azim to sum up the points from the implant team.
And from the implant team, when choosing the appropriate treatment for the patient, it should be kept in mind that every patient and situation is very unique. It's just not the same. So from the implant, as we all know, is more suitable when the duration is extended beyond the gingival level. And the second thing is when it's questionable to complete the root canal. For example, complicated root canal morphology, extremely curved root. And then implant also can reduce the treatment complexity of the patient, especially from the previous fail of the RCT, and can offer a long-term ability of the implant to retain a crown compared to endodontically treated with post-core and crown. And also it will be more cost-effective in terms of failed RCT, and we have to start doing the retreatment and everything. So yeah, why don't we choose implant, right? So thank you.
All in all, both teams presented very good points to support their topics. So it is up to doctor and the members of the floor to decide which treatment option, RCT or implant, is ideal for your patient, as each patient differ from the case. With that, thank you very much for your attention.